Thank you. Great to be here. These are my disclosures. So this is a how to do it paper, but I'll try to summarize some data as well. We know that partial thrombosis of false lumen is associated with an increased risk of aneurysm-related mortality. We didn't quite know that 10 plus years ago, but we certainly know that today. There's lots of evidence that says if you simply do TEVAR without addressing the false lumen at the time of initial repair or in chronic situation, there is late aneurysm-related increased risk of rupture and death. And obviously, with TEVAR alone for aortic dissection, 50 to 70% of false lumens might stay perfused. And there's lots of studies that have been designed to address this that are stent graft related and stent graft with bare metal related. So a long time ago, when we started to realize this in 2004 or 5, we wanted to just evaluate whether coil embolization of the false lumen would have any impact. And I remember doing this case that I'm going to show you for the first time. That was in 2004. But since we had about 106 patients that had complicated and chronic type B aortic dissections with or without aneurysmal degeneration, of course the chronics were with aneurysmal degeneration, that underwent coil embolization, and all the ruptures were excluded from this database, and the data was prospectively maintained. If you take a look at these 106 patients, false lumen embolization was done in 36 patients with TEVAR, 4 patients with EVAR, those thoracoabdominal aortic aneurysms that extend down to the iliac bifurcation, and of course, in the remainder 58, there was no coil embolization of the false lumen with TEVAR as well as with EVAR. This was my first case. I remember this was a ruptured aortic aneurysm. It was acute rupture with a dissection. I assumed that simply putting a stent graft in the true lumen will take care of this, but it did not. And what you're seeing, a little blush there, is retrograde flow into the false lumen. That's where the bleb was, and it was still perfused. At that time, the initial thought process was, this is in 2004, that simply relining the true lumen should expand the true lumen enough that it should get a seal proximally and distally, but it did not. And I found myself putting in 98 coils. Now, all those coils probably cost less than half a device cost, but still there were 98 coils. And what you see here is what happened, and the patient ended up surviving, the aneurysm sealed. Of course, every coil I put in at that time in 2004, I said, this is not going to work. It's not going to work. And you can imagine pushing 98 coils through that. But since we certainly have expanded our understanding of this and have used this routinely, here's an aneurysm, thoracoabdominal aortic aneurysm with a dissection, extends pretty extensively all the way down. The way to treat this, at least the way we have done this, is bring a stent graft all the way up to the proximal fixation site, which usually is distal to the left subclavian or sometimes proximal to that, and the distal fixation site all the way up to the top of the celiac artery. We want to maximize coverage, leave a sheath into the false lumen, and with this, simply use space-occupying lesions. These are just large 15 by 15 cm coils. You can use detachable coils. You can use all sorts of stuff. And then on the tail end, I tend to pack them with amplats or plugs so that the retrograde flow is halted. And what you see right there on the OR table is that the completion angiogram shows that there is no retrograde flow. And in this particular case, the coils were much more densely packed than sometimes I tend to do. And part of the reason is that there's no harm in coming back to recoil embolize as long as you are careful about protecting any complications of spinal cord ischemia, which of course there could be a higher incidence if you do significant embolization. Here's another patient who had a TEVAR and a subsequent EVAR for thoracoabdominal aortic dissection, but as you see at the infrarenal aortic neck, there's double lumen, and there was a false lumen endoleak that was going into the infrarenal component of the abdominal aortic aneurysm sac. And in this particular case, we did a translumbar embolization into the aneurysm sac and coiled these leaks. The coils I tend to use are coils that are detachable or controllable. I don't tend to use glue for this. These are very fluid states, and I certainly want to make sure that the glue does not migrate. Now, let me just bring you this from the beginning. This is a 56-year-old Marfan's patient. If you take a look at this dissection, it starts all the way into the arch. Ascending aorta is replaced. What you see here is that the innominate has a dissection. Left carotid and left subclavian arteries have a dissection. The ascending thoracic aorta has a tube graft, which was done about 10 years prior. And the aneurysm extends all the way down across the paravisceral arteries into and up to the aortic bifurcation. The iliac arteries are ectatic, and everything comes off the true lumen. The left renal comes off the true and false lumen. This patient was symptomatic. She actually came in with abdominal pain, and on examination, the aneurysm was tender to touch. And it was interesting how we decided to fix this. We actually staged this by a few days. This is the TEVAR component with a triple chimney going up to the innominate, left common carotid, and left subclavian. And then this is a retrograde four-vessel periscope stent graft. And all I'm doing is building the bridge in between the thoracic and the abdominal component. We did this case staged, but what you see is that the inflow and the outflow is sealed, the visceral vessels and the arch vessels are perfused. Of course, we wanted to make sure we preserve the hypogastrics. There was an endoleak from that proximal entry tear that you see, and I'll try to show this to you again. If you take a look at that innominate, the innominate artery had a dissection into it, which could not be sealed at this time, so there was retrograde flow into the false lumen from that innominate that you see. And in this particular case, to come in from the top to get into the innominate, we thought might be riddled with a few complications because of the high flow to the arch and to the great vessels. So in this particular case, we once again did a translumbar approach, accessed the aneurysm sac, put a 6 or 7 French sheath as needed into the aneurysm, travel all the way up into the thoracic aorta, up to the proximal most site of the entry tear, and then coil embolize that. And once again, the coils you probably end up using are in the range of 5, 6 Amplatzers and other detachable coils as you need. What I've learned is that you don't have to kill the entire endoleak in one sitting. You can certainly come back, and this is what you see in this Marfan's patient who's now 4 years out. I did this case about 3.5, 4 years ago, who now has survived to date, which he's probably 59 or 60 now. The endoleak is gone, and you see those visceral branches that are widely patent. So this has worked pretty well for us. If you take a look at this data and the outcomes in them, technical success is fairly straightforward to coil embolize, so technical success is 100%. Non-fatal complications in patients that had false lumen embolization was comparable to patients who did not. Paraplegia was comparable at 2.5% versus 1.5%, no difference. What was very interesting is that the 30-day mortality in patients that had false lumen embolization was 2.5% versus 16.7% in patients that did not. And 5-year cumulative survival was 87% in embolization group versus 75% in non-embolization groups. About 1/3 of these patients will require repeat embolization procedures. And I think you can use just about anything you need to embolize. The only thing I do not have personal experience with, because these are high flow rates in the endoleak channels, is I don't tend to use glue for dissection embolizations. We use it for endoleaks that are type 2 endoleaks, but not in these cases. Thank you.